So, Grant?
Hi, good morning, everybody. So one of our goals for the next 4 years is to get our slides up in time. So, we'll work on that. So it's something always to aspire to. So wonderful to see so many friends, mentors, and colleagues in the room. And just to say that, the National Summit has always been such a great conference and something that I've always really enjoyed participating in and learned so much. So there's a lot of collective wisdom in this room and really look forward to the discussion we're going to have afterwards. I'm going to talk about the national strategy implementation, where we are and where we're going, and I'm going to go pretty fast, so bear with me. Many of you will be very familiar with the data I'm going to show, but my goal is really to provide a context for continuing implementation and really stress that this is the President's National HIV/AIDS strategy. It remains a priority, and it's critically important for the health of the country that we meet the President's goals of reducing HIV incidence, improving health outcomes for people living with HIV, and reducing HIV-related disparities. So the strategy is a living document. I just went through the goals, and I think the critically important points about the facets of the strategy is it's not a strategy that says we must do everything at the same time for everybody. It's very evidence-based. It really looks at the epidemiology, and it really follows the science. It really stresses the need for evidence-based interventions that are concentrated in communities where HIV rates are the highest in the United States. It also calls for a collective response, and that includes both at the federal level, a coordinated response across federal agencies, as well as a shared responsibility, a collective responsibility to address HIV. So that includes the federal level, of course, but also engages the state, the community level, and other stakeholders, including private stakeholders, as well as community members who have really, I just want to say that the community has really driven much of the foundation of the strategy. And as you all, many of you will recall, there were 14 listening sessions before the strategy was actually published to make sure that there was full community engagement and input in strategy development. So really in distilling the principles of the strategy, really aligning resources with the epidemic, a shared responsibility, which I talked about, and accountability, that we need to look at what's working, we need to figure out what's working on the ground, we need to have the courage to change things that aren't working and to scale up the things that are. And again, really focusing on an evidence-based approach. You all know these data. Just to reiterate, about 50,000 new infections in the United States each year, endemic state level over the last 10 years. 64% of new infections are among MSM, a huge health disparity. MSM compared to other men in the United States are 41 times more likely to become infected with HIV compared to other men. And unfortunately, we are continuing to see increasing rates of infection among young black MSM. Among women, 23% of HIV infections, a level state of new infection rates. We need to continue to drive that down. When we talk about the U.S. epidemic among women, it's among women of color. African American women constitute 50% of new HIV infections among women, and Latino women constitute 20%. So basically, the take-home point is HIV in this country is an epidemic among gay men and among people of color. So one of the critical pieces is realigning resources with the epidemic, and really I want to shout out Ron Valdesari and Dr. Koh's office at HHS at HADIP, which is really charged with implementing the strategy. My office is the policy arm and directs through the President's voice where we need to see things move forward. And Dr. Koh and Dr. Valdesari have just done an outstanding job of actually implementing this. And CDC has really taken a lead in realigning resources with the epidemic. So this map shows the blue is the proportion of people living with HIV in the United States. The concentration, the darker colors are more concentrated level of HIV prevalence. And then the orange map shows the realignment of the alignment of resources, prevention resources that the CDC has realigned with the epidemic. So the point is here is that the alignment of prevention funding is being aligned so that prevention funding is equitable to the current HIV prevalence, the living HIV cases in this country. So a really important point. This is going to be a process that occurs. It's in progress now, and it will be complete by 2016. The take-home point here is that states and communities with higher levels of HIV in their communities are going to have more prevention resources. Before this, the formula was based on cumulative HIV cases. So the surveillance data is now mature enough that we can actually concentrate our resources based on the number of people living with HIV in the communities. So really a big step forward in terms of aligning our work with the epidemiology. So, our prevention toolbox, our toolkit is quite robust at this point. We've had major breakthroughs. Many of you in this room have been leaders in discoveries that have really helped fill the prevention toolbox. And at the same time, we don't know the best combination of prevention interventions to use in any one specific locality. So I think one of the pieces as we implement the strategy that's become really clear is that the strategy and the principles need to be applied, but also as you apply them, you need to be flexible to your local epidemic, to your community, to the people living with HIV and at risk for HIV in any specific place. So how do we combine these different aspects of our prevention resources and tailor them specifically to local epidemics? And this has been a real question as we implement the strategy. Exactly what mix is right. And I don't know that we have a specific answer to this. This is not going to be a cookie cutter approach, but I did want to talk about some really interesting work that has been done in Philadelphia, just as an example. This is modeling that was led by the CDC to say, okay, let's look at the Philadelphia epidemic. Let's look at the data, the general data about the efficacy of these interventions, and then let's see how you might target your resources. So this is really using evidence data to help model at a local jurisdiction level, how do you prioritize your resources? You get this contract from the CDC, right? You're assigned these dollars. So how do you actually, in an evidence-based way, say, okay, we're going to distribute this much for this and this much for that? So they looked at the epidemic in Philadelphia using the surveillance data, and then they entered the data about the efficacy of these various interventions. And what they found was that they looked at targeted interventions in clinical settings versus they looked at untargeted interventions that would be done in clinical settings, and then they looked at targeted interventions to specific populations. So what they found here was that given the epidemiology of the epidemic in Philadelphia, that testing in non-clinical settings for MSM was the most cost-effective intervention that they could do. And then they found also that adherence interventions and targeted and testing in clinical settings were the top three. So really interventions that emphasize testing and linkage to care, adherence to medications were the most cost-effective interventions. What they also found was that behavioral interventions for high-risk heterosexuals, sort of in the non-clinical setting, were the least cost-effective. And you really see there's a very broad range of cost here per HIV infection averted. So this is really an example of how the surveillance data, the data in the scientific literature is now being applied at the local level to help make more smarter investments in our HIV prevention work. We're actually working, Dr. Koh's office with Dr. Valdesari, Andrew Forsyth in that office is now working through an ONAP-supported project to really scale up this model so that we're actually able to help local jurisdictions make these decisions moving forward. And we need to do better. Many of you are very familiar with the HIV Care Cascade. Given where we are in DC right now, I'm referring to this as the HIV Care Cliff. And it is a cliff. I mean, if you look at these data, this is data on the Care Cascade brook. Can you guys in the back see these things? I can't imagine, but maybe you can. But you probably know this data well enough so you can just follow along. But in any case, this is the HIV Care Cliff, and you see that we have tremendous amount of work to do to lift these data up to where they need to be. Overall, only 25% of people living with HIV have a suppressed viral load, still very high rates of undiagnosed HIV. And these data are unfortunately even more concerning for people of color. You see that both blacks and Latinos do worse along the HIV Care Cascade or Care Cliff compared to whites. And we know that these care issues are directly linked to other social determinants of health, right? So this is data among heterosexuals looking in poor neighborhoods and looking at HIV prevalence and finding that people who live in poor neighborhoods who have other poor outcomes and other aspects of socioeconomic status and so forth have higher HIV prevalence. So this is really an example of where HIV prevalence is tracking with other disparities. And we also see this for specific populations. This is a meta-analysis that was published in Lancet. It's done by Greg Millett, who continues to work very closely with ONAP. And this is the care cascade for Black MSM. And this analysis compared Black MSM to white MSM. And as you can see, all along this cascade, you see that Black MSM compared to white MSM are less likely to be diagnosed with HIV, more likely to be diagnosed HIV positive, and then much less likely to engage in care, engage in early ART treatment, and also to be virologically suppressed. So a really important meta-analysis. I believe the sample size was over 6,000 here. So one of the critical pieces as we think about, especially that disparity among Black gay men, 48% increase in HIV infections over the last 3 years. This really calls home some of the seminal issues that we need to be addressing. When we look at HIV prevalence, so HIV diagnosis among Black gay men compared to white gay men, we see that lower income and a lack of healthcare visits were positively associated with these poor outcomes. So really, again, a call for a need to focus on the care cascade. How do we get our numbers where they need to be? So this leads me to the transformative change with regard to shifting the healthcare system in this country and healthcare coverage, the Affordable Care Act. And this is such a huge piece of moving forward in terms of improving health outcomes for all Americans. And especially when you think about where it's going to move our HIV care system, and you look at the coverage among people of color, 9 million uninsured Latinos will have access to coverage in 2014, and 7 million uninsured African Americans will have access to coverage. So you really see that this is a moment where we really have to seize the opportunity to realize the promise of the Affordable Care Act and to align it with the goals of the national strategy. The Affordable Care Act is a critical intervention moving forward for us to meet the national strategy goals. So it's not just about 2014, right? There's meaningful change going forward now. 54 million additional Americans are already receiving comprehensive prevention services, and in many cases this includes HIV testing. We estimate that more than 3 million young adults are insured by remaining on their parents' private insurance, particularly important when you look at the data that just came out from the CDC yesterday about HIV prevalence and testing among youth. And there are many other benefits that you can see here on the slide that have already occurred. In 2014, there'll be no denial of insurance coverage based on pre-existing conditions. This includes HIV, and many of you in this room are practitioners. I know that I and probably many of you have had conversations with people about getting HIV tested, whether they're insured or not. There's often a conversation, well, if I test positive, will I lose my insurance? Will I not be able to get insurance? So a really huge change here. We talk about structural changes a lot in what we're doing, and I think sometimes the things that are almost upon us, we actually don't necessarily realize what a truly transformative and structural change this is. And also, there's an investment in increasing the healthcare delivery structure, particularly I think relevant to our communities and our patients is the community health centers with a substantial investment over 5 years. So the other piece, I talked about accountability and really measuring where we're going and where we are, holding ourselves accountable for these interventions that we're placing on the ground. So one of the pieces that I'm very proud of that was issued earlier this year was an Institute of Medicine report on monitoring HIV care in the United States. This is an IOM report that was commissioned by ONAP, and I believe several of you in this room were on the commission. So thank you for your work. And this is really moving towards a national consensus. It's a very robust report, lots of wonderful detail there, but basically what the commission recommends is moving towards a solid but limited number of HIV outcomes to measure our clinical care, really applying the principles of parsimony, harmony, data that is actually achievable, that you can actually get, that you can actually continue to get, that's usable in a real world way and shareable. So we do a lot of data collection in many of our programs, and I think one of the key questions is what are the data that we really need to be looking at now? What are the data that and the burden that we can actually decrease so that we can actually concentrate on what we need to get? And how do we turn that around quickly so we're actually able to be nimble and adjust our programs accordingly? So the secretary has really taken this to heart. She issued a memo through her office specifying within HHS that that HHS needs to identify core HIV clinical variables and reduce reporting burden. Dr. Valdesari's office has really taken a great lead in this, along with Andrew Forsyth, who works in the office, and really working very hard within HHS to ensure that these secretaries' instructions are carried out in a meaningful way and have a real impact on the ground very soon. So we're looking forward to making sure that we're collecting the data that counts and getting the data back to you and back to other providers, so we're doing the right thing with regard to the national strategy. So what gets measured gets monitored, and one of the systems that we do see HIV care variables being monitored, I think, very well and being used in an efficient fashion is in the VA system, right? So a system where people have health care coverage, in a system where they have electronic medical records, in a system where they don't necessarily collect every piece of data, but they collect the most relevant data. And these data are from the VA and really showing that among how they're monitoring HIV care clinical outcomes and other relevant outcomes for our patients in their various sites. So a really nice example of a system that is very large, that takes care of a lot of patients, where they're actually using data to help improve outcomes and help improve their clinical care system as well. So it's not only about their patients, of course, it's not only about quality improvement for patient outcomes, but it's also about increasing the efficiency of your delivery of care. And what gets measured gets monitored, as Tom Frieden, now head of the CDC, says, and I think that this is really a great example. And Maggie, this is your analysis. Did you show this at the conference? Okay, as a poster or as a talk? Okay, so this is Maggie's work, and I think this is the HIV Care Cascade in the VA system, and it's remarkable how much better the outcomes are in this system, and it's also remarkable that they're able to actually measure this. So again, I think as we move forward with expanding healthcare coverage to more Americans, as we move forward with improving our data and feedback systems, this is really an aspirational model that we can look on and see, okay, what can we learn from this? Obviously, there's still more to do. Obviously, we need to continue to bring up these numbers even within the VA, but it's relevant that their outcomes in terms of viral load suppression are much higher than the national average overall. So there are a number of implementation research questions as we move forward. I'm not going to go through all these because I think my time is probably moving forward pretty quickly. But just to highlight a few things, what is the acceptable level of evidence to move forward with interventions? How long do we give a program to succeed? Where do we say in the field, okay, this is not working, how do we have the courage to change that? And as I already said, a critical piece is how do we adapt various interventions to the specific environments in which we work? We need more implementation research. These data were from recently published in the New England Journal of Medicine, looking at Medicaid expansion among adults in various states. And the take-home point from this paper was that health outcomes improved with Medicaid expansion. This is a much broader analysis than specific to HIV, but I think this is the sort of work that we need to be doing as the healthcare environment transforms, to make sure that we are really recognizing the promise of both the national strategy and the Affordable Care Act. So for the real detail-oriented people in the audience, just to point out, if you want to look through a large inventory of everything that's going on at the federal level across agencies with regard to implementation of the strategy, I invite you to go online and look at our National HIV/AIDS Strategy update. There's a lot of detail there. There's a lot going on, again, not only within HHS, but also in other agencies, including the VA, the Department of Labor, the Department of Justice, the Housing and Urban Development Agency. So a lot of different agencies are working together, aligned together to move forward to meet the strategy's goals. So lots of implementation strategy needs. Again, continued collaboration, especially if we look at things like Medicaid expansion. It's going to take a number of different agencies and factors to align, including at the state level, to ensure that this moves forward. We need to continue to set our priorities around maximizing the continuum of care. And as we move through our metric conversation, really realizing that there's a shift from a process-oriented metric measure to an outcome-oriented philosophy. So I think that's a very important piece. And then, of course, ongoing support for basic and clinical research. So much of what we're now applying on the ground started through much of the work that you've all done when you sit there and think, okay, how am I going to respond to this RO1 RFA, right? So we need to be able to continue that very critical component of our work. So I'm hoping with you in this room, you're part of that collective response, and that together we'll be able to realize the President's vision for the National HIV/AIDS strategy moving forward together. So just thank you very much. I want to acknowledge my collaborators and looking forward to a great discussion this morning. Thank you.